this land on which we meet. For me, it is the Wurundjeri people of the Kulin Nation, and pay my respects to the elders past, present, and emerging. Now, very good afternoon again, and welcome to this very exciting series on technology from a clinician perspective. The ARC Training Center for Medical Implant Technologies has in the past invited cardiothoracic surgeons, plastic surgeons to share how technology has impacted their practices. This has been really an eye-opening sessions, especially for engineers like us. So today we are extremely delighted to have Associate Professor Yi Tang, an orthopedic surgeon, to give us and share his views on technology. Now, Associate Professor Yi Tang, he's a Melbourne-trained spine surgeon specializing in the care of spine in both children and adults. So his focus has primarily been on the spine, ranging from pediatric conditions such as scoliosis to traumatic and degenerative conditions in adults. After completing his medical degree and orthopedic fellowship in Melbourne, Yi has completed spine fellowship in California and in Toronto. And in overseas, he gained extensive experience in using some of the latest technology in spine surgery, including computer navigation, robotic surgery, minimal invasive spinal surgery, and his latest technology in correcting deformities for both children and adults. So Yi has an appointment at the Royal Children's Hospital, Royal Melbourne and Epworth Hospital, and he's also an honorary associate professor through the University of Melbourne. Right, we certainly look forward to Yi's talk. Let's welcome Yi.
Thank you very much, Peter. Thank you for asking me to talk. Very excited to engage with everyone, and I think it's a great lecture series. I watched the one that Professor Jason Chun gave last year, so hopefully this is a slightly different perspective on the use of technology, especially in medicine and surgery. So I'll get started with my talk. So I was basically asked to talk about technology in my use or in my practice of spine surgery. This is meant to be a more of an overview, so please feel free to ask any questions. We'll also leave time at the end for questions as well. So to give you a background, as Peter mentioned, I mainly deal with all conditions of the spine in both children and adults, and I also hold an honorary clinical associate professorship here at the University of Melbourne. In terms of disclosures, I'm not a radiologist or engineer or mechanic. I just have to deal with this stuff every day, like some of you have to as well. I did pass Year 12 physics, and I can operate an iPhone, so I'm not completely a Luddite when it comes to technology, I guess, and I do consult for device companies, and I'm currently developing implants with the University of Melbourne, which should not impact on this talk at all. In terms of acknowledgements, Dr. Peter Newton, who is the supervisor that I spent time with in San Diego, a lot of the illustrations and diagrams are courtesy of him. Mr. Paul Bentley, who provided a lot of the videos in my talk from Epworth Medical Foundation and the Children's First Foundation, and Nicole, which is one of the examples I'll use later on. So to start the talk, I just wanted to quote Aristotle, who essentially came up, I'm sure the actual phrase is not this, but the more you know, the more you realize you don't actually know. And I think we're very much in that phase of medicine, and especially in spine surgery. So in terms of technology, what really is it? It's basically the use of knowledge for practical purposes. So here we see this difference between engineers, of which the majority of people logging on today will be, or people who work around knowledge, and then for practical purposes, which is right at the other end of the scale where I'm at. So essentially there's a continual dialogue, but from me to the engineers and vice versa, about what we can do to apply what we know to try and help our patients. Probably one of the simplest and earliest forms of technology, is really just a rock on the left-hand side. But when it's sharpened, it becomes a tool. You can use it as an arrowhead. You can use it to hunt and kill, and, all the way to the current evolution of the rock, maybe 500,000 years have passed. but the applications are still very similar. And this is an example of how we use our knowledge to actually help us with our everyday lives. So a lot of my talk is about examples and vignettes. This gentleman here is a very famous surgeon, Scottish surgeon, and this was in his theatres in the late 1800s. He was very famous in being able to amputate people's legs quickly or perform amputations quickly. And you needed to in those days because there's no way to control bleeding. There was no way to actually stop bleeding. The patients didn't have analgesia or anesthesia. This was the start of the use of either, which is where you see that bottle on his right and then there's no antibiotics. So he was, famously able to lop off legs in about, I think as quick as was 2.5 minutes, he was able to take off a leg, usually for infection. He also has the dubious honor of having the highest mortality rate. In one operation, he managed to have a 300% mortality rate. So he could actually, the patient died from overwhelming infection. He accidentally sliced through his assistant's finger, who then succumbed to infection and died. And one of the observers, as you can see there, fainted and hit his head and passed out and died. So obviously, we try and avoid that during modern surgery. This is an example of a modern operating theatre, so roughly 200 years apart. And you can see it looks slightly different, and not because of the sepia tones. We now have antiseptic, we now have antibiotic, we now have anesthesia. You can see everything to the left-hand side of the drapes here is all dedicated to keeping the patient unconscious, asleep, and their pain relief. We have modern technologies to assist us in performing the surgery. Our operating theatres don't have people looking on anymore. The people that are looking on are helping during the surgery. And so the thing about technology is that some idea seems really good at the time. I don't know how many of you will remember this movie, but this is Back to the Future with their hoverboards, which seems like a really cool idea, and hopefully someone's still working on an iteration of this at this stage. And while some ideas seemed like great ideas at the time, others were very good. So this diagram to the left is a form of tourniquet. They were hoping to be able to stop the bleeding by applying pressure, which would work in principle. But obviously, you can only tourniquet so much of the head. But in fact, that's how the tourniquet was developed, was someone putting a giant rubber band around the head. And here is a photograph of people applying plaster jackets to a girl with scoliosis. You can see this is, pretty brutal sort of thing that they're doing, but it actually works. And to a certain extent today, we still do this, not in this form, and the patients patients get general anesthesia, but it just shows that some ideas still last the test of time. And our plaster of Paris, for example, has that name because it came from these times. So what is progress? It'd be nice to think of progress as this linear arrow. First, you understand what's normal, then you understand what's abnormal, then you understand how the thing with abnormal pathology behaves. So that's the natural history of a disease. Then you can work out ways to diagnose it, treat it, and then eventually prevent it. And the holy grail is cure. So to apply to something that's close to my heart, scoliosis, right, which refers to a curvature and rotation of the spine. So our anatomy understanding is fairly worked out. We know that people have a spine. We know roughly how many bits of bones and ligaments and tendons and nerves are in that spine. Our understanding of pathology mostly fits. We know that in people with scoliosis, their spines are curved. Now, how exactly they're curved, we're still working out on that, but it's mostly pretty good. In terms of natural history, we've had several long-term studies. Some go up to 50 years, some go up to 40 years. And we sort of know how they would behave. If you have mild scoliosis, they don't tend to get worse. If you have severe scoliosis, they do tend to get worse. So we can actually offer a patient some natural history. If you were to leave your severe scoliosis, this is likely what's going to happen. And then diagnosis. How do we work out what's wrong with someone? And most of the time, it's like, we can now have x-rays and fancy scans to work out what's going on, so we can see much more than just examining the patient. And most of our treatments, although they're fairly new, we still use things like plaster jackets a lot of the time. Now, prevention and cure, we think it's largely genetic, and so we're still not really very good on that. And so I'm not sure if this actually represents progress in the sense that there's been a linear development. What I think tends to happen more is it's circular, and many things are actually going on all at the same time. So you have this Technicolor donut. What happens is that we tend to see someone come up with a new understanding. For example, we have development of a new way of diagnosing things, which changes our views on pathology. And we say, oh, geez, that's not quite what we thought, which then might change our natural history. And to be able to track these patients over 30, 40, 50 years is a very difficult task. And so then that changes our views of treatment, and further in terms of prevention and cure. For example, there are people that are looking for scoliotic genes on patients. We know that scoliosis affects girls 8 times more than boys. We know that it runs in families. So it's most likely there's something in the patient's genes which contribute to this. And through the use of things like modern social media, which is both a blessing and a curse, we can help educate and share this information. So, coming back to scoliosis, this is around Hippocratic times, and you can see that the treatment is not necessarily the most elegant. They used to try and suspend people, which is still kind of what we do, but we don't hoist them up like this. This looks like sort of torture device, but from little things, big things grow, and everything has to be developed from something. So you say, so this is French, and it was around the sort of 16 to 1800s. And this is actually not so far from what we do currently. And if you look, I'll show you an example of the late sort of Victorian times, early 19th century. They started to develop into corsets. And the reason why they had to do this is because it was hard to convince a patient to wear this. As you can imagine, you wouldn't want to put your own children into something that looked like you might, put in the fireplace. And so appearances and patient acceptance started to come into it. And here you see someone who was being tractioned, or they would grab onto this bar to try and straighten the spine, of which we still use today. And here we have the modern day iterations of these braces. Now, I can tell you that most people don't smile like they do. These are obviously models, but we still use, for example, the Boston brace and the Chanel brace and the Milwaukee quite a lot. These were sort of late 90s, 80s, 70s in the 1950s onwards. And we still use this technology today, but it's developed over 400 years. So one of the things that technology allows us to do is to have new ways of looking at things. This is a slide of Galileo, of which most people would know who that is. This is the Doge of Venice, who's like the leader of Venice. And here's a picture of Galileo showing a telescope to then the ruler of Venice to show him what you can see. Before then, people looked at the stars and thought that we lived in a sort of crystal ball surrounded by the stars. But then when you can actually see things, you can observe them. Unfortunately, Galileo did not meet a great end. For those that you don't know his story, he was essentially accused of being a heretic by the then Roman Catholic Church, and then confined to house arrest for the rest of his life for coming up with controversial ideas which did not fit with the then religious beliefs. And so there was an inquisition, and subsequently he was locked up for the rest of his life for his beliefs. So showing you actually pictures of scoliosis. This is a patient who's very typical presentation of scoliosis. You can see that scoliosis is both a curvature in the spine as well as a rotation in the spine. So their trunks start to spin, and you can see the right side, the rib humps become prominent. And you don't necessarily need an x-ray to know that this person has scoliosis. What's interesting is that This boy, for example, also has scoliosis, but looks quite different to the girl that I just showed you. Traditionally, we would get an x-ray and you would say, here's the curve. We would measure the curve. We would then recommend treatments based on how big the curve was, because we had a good idea of what the natural history was. Now, this may look like a plain x-ray to you, but it's actually a very new technology called an EOS scanner. EOS is a proprietary name, it's French. This machine was developed by a Polish physicist by the name of George Szczepak, and he actually won a Nobel Prize for this in '93, I believe. But basically, it minimizes the amount of radiation that you need, which is important for people because, especially young children, they're getting repeat X-rays over and over again through the course of their lives, which can then start to cause their rates of cancer to go up. But the other thing you can do with EOS scanners is you can create a model of their spine from what looks like an X-ray, and then you match it to their age and in some respects their ethnicity to have a rough idea of what their spine is going to look like. And then you can individually segment these spines based on landmarks that you see on EOS scans, and you can see that you can create 3D models. So this was probably in the last 20 years that it's come out, and it's helped us understand this disease a lot better. So in creating a 3D model, you can see that how rotated this part of the spine at the apex of the curvature almost goes outside of the pelvis. And these pictures that I showed you are a courtesy of Dr. Peter Newton. And you can compare them with someone who doesn't have scoliosis, and you can see the huge difference that they have in their spines. So from this, you can then individually take out the rotation of each vertebrae and how much they tilt, and then you can stack them back up in their true lateral plane. And from then on, you can reconstruct this and see how much curvature, not just in their coronal plane, so looking at them from front on, but if you look at them from side on, that their spine is actually extremely curved backwards. And then we now know that the more curvature they have in their spine, the more extension or the more curve. So you take a really severe scoliosis and you can see when you stack them all up in the correct plane that this person's spine is actually way bent back. And the reason for this, we think, is because scoliosis occurs, or part of the reason is that the discs and the bones grow more in the front than the back, and there's a relative mismatch. So your body can't have you looking up at the ceiling the whole time, so it actually rotates these to better accommodate so that you can still look in the horizontal plane, but then it creates these curvatures. So this is something which we didn't really understand all that well up until, I would say, late 90s, early 2000s, which is very, very late if you think about how long we've been studying this disease for. And from these, we can make generalizations and measurements about their sort of measurements. And here, once we have new understandings of things, we can also have new ways of doing things assisted by technology. For those of you that don't know this gentleman, he's an ophthalmologist by the name of Alan Scott. He's largely credited with the invention of Botox. And he invented Botox not to, put into people's foreheads, but more to put into people with this condition called strabismus, where they get their eyeballs flicking from one side to another. And previously, you might have to do an operation to cut the muscle or weaken the muscle, but now he's like, well, I can use Botox, which is essentially a bacteria that denervates the muscle to then stop them from moving. So you weaken the muscle. And we have in Melbourne an expert in this area as well. This is Professor Kerr Graham out of the Children's, who really started pioneering the use of Botox in children with cerebral palsy so that you can selectively denervate their muscles, because cerebral palsy is largely a disorder where the muscle imbalance creates secondary deformities in bones and joints and ligaments. And of course, you have the actual use of Botox in today's society, which is largely for cosmetics. And you can see that it's got a huge uptake and it's ubiquitous in today's society. That the use of Botox can help with aging. Now, coming back to scoliosis. So for many years, spinal fusion was what we still use. And it's still considered very much the gold standard. We get excellent results based on the surgeries that we do. You can see this child presented to me. She had about 110-degree curvature, which through an operation, spinal fusion, insertion of screws, rods, and I'll talk about this a bit later, she's almost straight, which is an amazing sort of, to consider what we can do with someone's spine there. However, through the use of technology, through the development of new materials, so we now have things which we're pioneering. So this thing is called tethering. It's basically a fusionless surgery for scoliosis, because one of the concerns was also, if you fuse this many levels of the child's spine, is it going to impact them down the track? The answer is actually largely no, which may surprise a lot of you because you say, well, this segment is fixed, but we usually don't move a whole lot through this segment. But in the last 10 years or so, there's been some new technologies or new techniques, and tethering is one of them. So we would put screws into someone and say, well, there's meant to be a rod joining this, but it's actually a plastic or polymer cord, and it acts like a rope. And how that works is it actually tethers the side which is growing more, which we only understood through fairly new ways of looking at the spine. And so if you hold the side that's growing more, so it doesn't grow more, and if you allow the side which is not growing as much to catch up, then you can potentially make someone's spine straighter. So this is someone 2.5 years down the track, which is, again, an amazing result. And, this person technically still has some movement, although there's really very minimal movement there to start with. And you can see, you can do reconstructive EOS scans, like the technique I showed you earlier. This is them before their procedure, and this is them 2.5 years later. And this is some of the work that I did when I was overseas, is that if you followed their growth, and each of these EOS scans that are done 6 months apart, which were then reconstructed, you can almost see that the bones on the convex side, which is the side that's growing more, not growing anymore, and the bones that are on the concave side within the apex of the scoliosis catching up. So it actually equilibrizes through the bone, and that's some of what helps with the correction. Now, this is very experimental technology, although it is starting to be offered. And, I come back to saying that the gold standard is still very much spinal fusion, and that is the majority of my work. Now, that's because not everything new is better. I'm not sure how many of you know these two gentlemen, but the gentleman on the right is largely responsible for the pioneering use of lobotomies, which essentially you put a needle into someone's frontal lobe, either through their eye, or you can do it through a small surgical incision in their skull, and you take out some of their frontal lobe. It is done between the 1890s and in some parts of the world as late as the 1980s, which is pretty incredible. It was done in children as young as 12 years old, all the way to adults. And it was done for basically a variety of mental health disorders, so to speak, ranging from schizophrenia to bipolar to what sounds like ADHD on some of these diagnoses. All in all, it's thought that about 40,000 cases were done in the States, 17,000 in the UK, and 10,000 in Scandinavia. And I think most people know enough about this procedure to know that it was a horrible procedure. People either died from it or they never were quite the same. And the famous movie is One Flew Over the Cuckoo's Nest, where Jack Nicholson's character eventually underwent a lobotomy because he was so difficult for the people to control in the sanitarium that he was in, or in the mental institution that was in. And highly recommend that movie if you haven't seen it. And it gives you some perspective to sort of view this technology, because at one stage it was red hot. People were doing it all over the place, and it very quickly fell out of favor. Although you can see that some people still were doing it well into the 60s, 70s, and 80s. So here's an example where this procedure was probably not all that it's promised to be. Here's an example in spine. And so there was a technique that was developed in the 90s where people thought it might be good to actually do a spinal fusion either through the bum itself or through the bowels. So they used to actually put a screw adjacent to the bowels or through the bowels into the disc space. So in terms of surgical principles, you would actually go through a very dirty area, that being the colon and the areas around the colon, to then go into a very sanitary or sterile environment, that being the disc and bones. And this procedure very quickly fell out of favor, although it was taken up around the world at one point. So it's often really hard to know at the time what is a good technology and what is bad. And here you see an example of a biblical or historical drawing of Lot's wife. So this is when, I'm not sure how many of you are familiar with the Old Testament, of when people, or Lot was fleeing Sodom and Gomorrah, and his wife turned around and looked at the city that she used to live in and turned to salt. So it just goes to show that hindsight is often really good, but can often be quite dangerous as well, because the thing with hindsight is that once it's done, it can't change anymore, whereas the present, it's constantly evolving. And this is the sphere that we all have to work in. An example of where some, like a technology has undergone multiple iterations to reach one of the most successful operations currently. So if you're going to have an operation, you probably want a cataract operation, a heart bypass, or a hip replacement. These three, bang for buck, are your best operations. But the hip replacement didn't always enjoy the current status that it has in terms of how successful it is, because of material properties, because of surgical techniques. It started off, people were putting ivory and plaster into people's hips, which is pretty crazy if you think about it now. But again, that's what I was talking about with hindsight. So you can see that back in the late 1800s, when ivory was used for a lot of things, people did that. Didn't work very well because it broke a lot. And then people started using things like glass, rubber, plastics. And it wasn't until the sort of 60s and 70s that there was a gentleman called John Charlie out of England who put polymers or plastics as the bearing surface that really, and he actually tested it on himself first. He actually put the polymer into his thigh to make sure that it was inert and that was a good bearing surface. So, you know, this really took 100 years or 80 years to get to where it is today, but now it's one of the best things you can do if you have hip arthritis. An example of that might be in spine surgery. This is a disc replacement. So it came in the late 80s. It was really heralded as potentially sort of, we can now have the technology to replace our discs. Sounds great at the time, but we found that there was a really high complication rate, and that was because of the way things loaded. And, you know, this is piggybacked on the back of hip replacement success. And it's like, if we can replace the hip, why can't we do the same thing to the joints and the spine? And unfortunately, when you change the parameters, then all of a sudden things work completely differently to what you think that it would work. And we still have modern day iterations of this, but in relation to this particular prosthesis, you can see that a lot of modern day reviews aren't particularly favorable anymore. So this prosthesis now is no longer being offered on the market. There are other models of disc replacements, and, you know, I for one occasionally perform lumbar disc replacements, and just generally for younger people where we don't have great options for discs that are very degenerate. These are cervical disc replacements. So we put these disc replacements in the neck, and they actually work much better. I actually put quite a few of these into people's necks, and I find that the rate of revision, as in needing to go back and do something after you put the disc replacement in, to be quite minimal. So you can see also that in one part of the spine, lumbar disc replacement's not quite there yet, not a fully mature technology, but in the neck, much, much better. And that's probably because of the biomechanical loading of the actual spine itself. So onto some notable technological advancements. This is sort of specific things that I have in my practice. Everyone wants to know about the toys, navigation. So essentially, why do we need navigation, which is a fancy way of saying we have something to help us guide to do our surgeries, because this is what a scoliotic spine looks like. You would expect it to be in the center, but it's actually a kidney there in the center. You can see this person's kidney there. Their spines are so rotated in some of these people that we operate on that it's not anywhere near where you think it would be. So the anatomy is very different. It's very difficult. You often don't see all that much because all you see is from the back. We don't actually get to see any of this. And then you're often putting quite a big screw into quite a narrow corridor, and that's the corridor. And you can see on the left-hand side there that this is a tiny corridor of bone that you really don't have any margin of error. And the consequences of not putting it in that corridor is horrible, because you have the spinal cord inside here, which we don't want to be anywhere near. You have the lungs and artery out the front, and you have the kidneys, and all of this is within a centimeter of each other. So the risks or the consequences are extremely high. And you can draw a parallel with the aviation industry. So this is a clear day. This is minimal crosswinds. You can see everything. I think most pilots would be very comfortable landing this plane just by looking at it. You don't need anything fancy. I'm going to show you a video. This is an aircraft landing. So this is an F-18 Hornet as part of the United States Air Force. And you can see that this person had to land a $20 million plane within the space of, say, 300 meters, traveling at around 300 kilometers an hour. So the margin for error, all of a sudden, it looks completely different between this and this. And if you miss, your airplane goes into the sea and you can really never be a fighter pilot again. And then we can take it to the next level, which is night carrier landing. You can't see anything, so that's the slide. Well, I'll actually show you a video. So this is what a night carrier landing looks like. Oh. Sorry, I'll try and get the video to play here. Okay. So even compared with the day carrier landing, this is a completely different prospect, because you literally cannot see. They can't light the aircraft carrier up because you're often in a war zone and you don't want people firing missiles at your aircraft carrier. So all the lights are off. There is no way anyone can land this plane without actually using assistive technologies and communications and instruments. So basically everything is done via navigation, which is similar to what we have to do in the spine sometimes. So taking this example on board, you're essentially flying by instruments. I went on an aircraft carrier. This is in San Diego, and this is actually where they shot some of the Top Gun stuff. And I, studied this technique. No, I didn't. I just thought it was very interesting. And we have similar instruments now to help us perform spine surgery like this. You can see that we can bolt on these navigation arrays to our instruments. You can see the spine being exposed there. And this actually talks to a camera up there to then help us guide to where we are in surgery. And we can do this with a variety of instruments. Here you can see reflector arrays on all of the instruments, which talk with the camera to help show us where things are on a screen. This is me and my colleague operating at the Epworth, which is one of the private hospitals here in Melbourne. And you can see all of a sudden the patient scans on a CT, and we can use that as reference to then be able to help us with our surgery. You can see when we're actually on the spine, none of us are actually looking at the patient. A lot of what we do is on the screen because you actually get a lot of information. And so we can place the screw where we want it to be, and rather than sort of going either side of it. And in the end, it can look pretty funky, but then you get really good results because you know your screws are in the right place. And there is a measure of safety associated with that. It can lead to some unexpected findings. So this is a patient of the Royal Children's, is a young kid that we were going to do a neck operation on, and we actually found the erroneous or abnormal vessel on one side. And so you can see that this vessel doesn't exist on the other side. And this helped us modify our surgical plans, because normally we would put screws on both sides, but because of this very large vessel, we just put screws on one, because if we were to put screws to the other side and cause a lot of bleeding, that can again lead to some very catastrophic consequences. And then finally, some of the deformities that we deal with are so difficult and complex that it's often helpful to try and understand them before we actually go in and operate. This is a traditional CT scan, and you're looking at this trying to make sense, but nothing really makes sense. But through the use of 3D printing, for example, I can get this spine made before the surgery, and as a result, I can have a plan going into the surgery knowing exactly what to do, because the operating theatre is not really a place that you want to be thinking too much in. And that sounds funny, but when you have a patient that's anesthetized, that's bleeding in front of you, you really just need to get the job done, so to speak. So it's good to plan beforehand. I'm going to show you a case study. This is a patient of mine who is actually arrived in Australia through a charitable organisation. She's a 12-year-old girl from the Philippines with scoliosis. This was her films when she first sort of came over from the Philippines. Not terrible, but not great. And over the course of 18 months has really progressed rapidly. And you can see that she's gone from roughly 50 to 60 degrees to 100 degrees. And both curves have progress very quickly, because scoliosis tends to get worse as you're growing. Here's one of the things we can do, which is actually create 3D reconstructions. And so again, that helps us to work out what's going on, which is the fact that her spine is really bent and curved. This is Nicole getting on an aeroplane. You can see how she stands there with her parents before she is coming to Australia. So she's flying out of Cebu there in the Philippines. Next, I'm going to show you a video of basically the journey that she had.
What you're looking at is a cast of probably 10 to 12 people in theatre, each with highly specialised jobs to make the surgery run as safely and smoothly. They establish IV access to make sure that we can monitor all of her physiology, including her breathing, her heart rate, her blood pressure. We start doing the neuromonitoring side of things. So we actually connect small electrodes to her head and also the rest of her body so that we can map her spinal cord during the surgery to make sure that it is working as expected. Finally, we actually get her to cutting the skin, making the incision, and then starting to put our spinal screws in. And we do that with the aid of computer navigation. That allows us to basically put spinal screws in much more safely, because we can actually visualize the size of the pedicle or where the screws are going into. We then connect up all of the screws with a rod so that we can fix it in its final place. That's how we get from curved to straight.
So
what you're looking at is
x-rays of her prior to her surgery and x-rays of her afterwards. You can see that she's not perfectly straight, but that was really never the goal of the surgery. The goal is to stop her from getting worse. And I'm pleased to say that she's doing very well. She's now back home in Australia after spending about 12 months here. And you can see that the posture she stands at is completely different. She's now taller than her mum as well, which is very pleasing. And this was over about the course of 12 months or so that she spent in Australia. So just some of the ways that technology has helped me and my patients is that I now understand things differently. I now see things differently. You can use, even through this Zoom meeting or webinar, this would never have been possible 10 years ago, that we can now conduct these sort of lectures online, and this is all sort of a very new technology. The use of different materials, material properties have really helped us a lot. There's been multiple iterations of implants and different mixtures of alloys. Our tools are very different. Technique can be very different, which then flows on to recovery. So just looking back even in the last 20 years, which is not that long ago, because really that's how long we've had mobile phones for. spinal implants have completely changed. We had spinal implants as far back as maybe the early 1900s, but there's been so many different iterations, much like hip replacement things. We now have navigation to help use these implants much more effectively, spinal monitoring that I've touched on. Cell salvage is where we actually suck up the blood that we lose from the patient. Then a technician washes it, and then we're able to give it back to the patient or transfuse it back to the patient. We used to actually take the patient's blood before the surgery. And then we used to store it in the fridge and give it back because we know they're going to lose blood. But now we lose less blood and we can actually just give it back to them on table so they don't have to go through that again. There's new operating theaters, there's new operating tables, there's new ways of doing anesthesia, there's new ways to investigate things. And, you know, as I said, coming back to things like even telecommunications, nowadays you see a doctor through a computer screen because sometimes because of COVID as well. So coming back to what I was saying, from little things, big things grow. Paul Kelly sang about this. In the space of 200 years, you've gone from this operating theatre and the way that surgery is being done there to this operating theatre. There's so many little incremental changes, which are actually largely because of scientists and engineers more than actually doctors. We say this is what we want, but it's actually you guys that have to actually help us put this together. And that's why there's an ongoing dialogue. And that's one of the things I really enjoy working at the University of Melbourne with Peter and his staff, is that I can tell them things of this is what I want, and then they can go and come up with a solution, because they're generally a lot more intelligent than surgeons in general. So we live in exciting times. There's lots of applications for knowledge, and things will constantly evolve. This is, I guess, a stylized portrait of Nicholas Copernicus, who first sort of came up with this idea that perhaps not everything revolved around the Earth. And he didn't really go as hard on the theory as Galileo, but you know, someone had to start the theory back in the 1500s. And now, I love looking at the NASA website. We're talking about going to Mars. From this time, when you didn't even really know Mars existed, 500 years later, we're actually going to be able to land on things. And sort of, if you just imagine that, looking out your window at night, that eventually, maybe within our lifetime, someone will be able to set place in a place like that and perhaps establish some sort of colony. So, and then to finally put it all into perspective, this is an example of the scale of our galaxy. Each of these dots represent a universe of which we're maybe a tiny bit part of. And so the things that are out there that we don't know at the moment are way more than the things that we know. And so if anything, hopefully it's given you some inspiration to be able to look further and to learn more so that you can change things, because this is really how technology helps us and assists us in our everyday lives. So that's the end of my talk.
Thank you, Yi. This is really, really fantastic. It's you put everything in a nice perspective. How technology has kept what you are doing and doing them well as well. I'm still have questions in my mind, but maybe before I kick off, I can see a question on the chat box. Yes, so please feel free to put on.
Absolutely. So what I'll do is read out the question, and we have lots of time, so please feel free to ask anything you want. Great talk. Thank you. Probably didn't need to read that bit out. What do you think is the role of patient-specific implants / custom-made implants in spine? Do you think that's where spine specialty is headed? Is it really beneficial compared with off-the-shelf to spinal implants? So here's an example of patient-specific implants. Basically, you generate a 3D model and you can then customize a jig, which then sits on the landmarks of the spine. And that's exactly what this technology is doing, so that this jig sits on the spine and you're able to then put it on there, and it sort of guides to where you want. Now, That sounds really good in principle. However, there are certain practical things, and this is the interplay between surgeons and engineers, because when I have a thing which tells me exactly where to go, it relies on 100% trust of that technology. And surgeons tend to be a little paranoid, and you don't always know if you're in the right place or not, because even if you're 1 degree off at the entry of the pedicle, if you go 10 millimeters further, you could be 5 degrees off or 10 degrees off. Then you could end up in a place that you didn't intend to be. So I have used it. I think there are definitely applications for it, but we're not quite there yet in regards to the technology. There are 2 or 3 companies in the world that are currently doing it, and certainly good for certain applications. So hopefully that answers your question, Upa. So from Dale, Rob Robinson, I hadn't seen that insight about scoliosis before, where it actually arises from a misalignment in the sagittal plane. Apart from the discs, do you think it could also arise from excessively tight ligaments or incorrect muscle activities? So definitely there is a group of children that, so the majority of scoliosis that I'm talking about today, not this kid, because this kid has congenital scoliosis. You can see they have multiple bones, but the majority of scoliosis that we tend to see would be, for example, adolescent idiopathic scoliosis. And the word idiopathic means we don't really know the cause of why that happens. And however, there are a group of kids such as those suffering from neuromuscular disorders, things like cerebral palsy, things like Duchenne muscular dystrophy, that do have significant muscle imbalances. And I'm sure that the different pool of the muscles will influence the shape of their spine. And we tend to treat them differently because the goals of surgery are very different in those group of children. We don't want them to be absolutely straight. We want them to be able to sit much better. We want them to be able to be cared for much better, because often, they're not the same group of children. And this is why it's a difficult disorder to sometimes manage, because there are many different manifestations of it. Scoliosis is really just a description which talks about rotation and curvature of the spine, in the same way that a headache is a description, but the actual causes of that are many. And so they can definitely be caused by different things.
Yi, there's a question on the Q&A box. Says, could you discuss the design of the technology, maybe examples of well and poorly designed technology and its impact on your work, patient safety, acceptance, error, or anything else?
Yeah, sure. So we can actually talk about, can we talk about what we're doing?
In general, yeah, I think that's...
Okay, sure. Well, it's not a big secret, right? So, we're currently designing some technologies sort of around patient-specific implants, which I think goes back to one of the questions I was asked before. Patient-specific implants, can we do something to match the patient's anatomy? Now, I didn't put this slide in here because it was getting a little nebulous, but how do we actually know what is normal for that patient? And the answer is we don't know, because everything is so different. Unfortunately, we don't come off a production line. So, we're all made from flesh and bone, and mainly carbon, of course. And so what we think is normal may not be what is actually normal for our patients, because we all live on this bell curve. And what we think is normal for them at 20 is maybe not the same as what we think is normal for a patient when they get to 60, because our bodies naturally change. If you try and put perfectly white teeth on a 60-year-old person, it looks really weird, because that's not how people perceive normal, or that's not how normal is. And so therefore, if you try and design custom implants to what you think is normal, it may not actually fit that person. And also the practical applications. So for example, the current PhD student, Yi Tang, was like, well, I've done all these finite element analysis, and your spinal cages should go right at the edge of the spine. That's the best place for them. And that's 100% correct. But the challenges of actually getting that there is so difficult. During the surgery, I told Yi Tang, there's no way I can put this cage where you want me to put it, because right in front of the cage is the arteries. And if that cage goes out 1 millimeter ahead of where it should be, for example, here, this is the lung on either side. So if you want me to put the cage there, then that procedure becomes very risky. That's the aorta there, that's the vein or the vena cava. So you really leave me with no margin for error. And this is where, you know, as engineers, you might think, well, you guys should just do this because it's the best. And, you know, there are some implants that are made like that, but then there are real world things which restrict us from doing this. And this is where that in dialogue is so important.
Yeah.
I hope that answers the question.
Good example. There's another question around, so it says, great talk, really opened my eyes how little changes can lead to huge impact. So once the implant are put in patients, will the spine continue to shift and therefore require further surgery?
So generally, once the implants go in, especially for a fusion operation, the aim of fusion is to join the bones together so that they don't get worse. So basically, this segment that I've shown you won't move. But what we do know from biomechanical studies is that this part largely doesn't move anyhow. It's the bottom 3 parts of your spine that move the most. And so we try very hard to stay out of the bottom of your lumbar spine, because the lumbar spine is actually very unique to humans. We are the only bipedal animals in the world. You will occasionally see bears and gorillas walk on 2 legs, but that's not a full-time thing. That's what they do for exception rather than the rule. Now, as a result, our lumbar spines, which are actually meant to be quite stiff and short because it's helpful for climbing trees, now need to be quite flexible in order to accommodate for our motion and bipedalism. And that can have an impact down the track. So the parts that are fused shouldn't really move and shouldn't really need revisions, but certainly the parts above and below can degenerate more quickly because you're still having the same force travel through your spine, but that force is now being taken up by less discs. And this is where we have to make a compromise because, you know, if I don't fuse this curve, I'm sure that it will get worse. And then, you know, I leave you with a very tilted spine. So then I know that the long-term history is that you'll probably develop degeneration if I go down to here, but the problem is if I don't, you're going to run into bigger problems. And this is where, again, you have to work in the real world, and it's always compromise. It's never absolutes.
Yeah. Yihan has a question about, say, the extent of range of motion will be lost for patients who undertake fusion to treat scoliosis. So based on the experience, what is that loss in terms of range of motion?
So that really depends on how much you fuse, and how much you fuse down in the lumbar spine is the most important. The thoracic spine naturally doesn't move that much. It's maybe responsible for a little bit of rotation, a little bit of flexion, but really not anything noticeable. I have patients that have had thoracic spine fusions that, you know, will go back to doing professional ballet, professional gymnastics, because you can't have your rib cage move a whole lot. Otherwise, it's going to crush your heart and your lungs every time you do move. But the lumbar spine is more responsible, and in particular, the bottom 3 levels of the lumbar spine. So from L3, L4 downwards. And so that's why we always try very hard to stay out of the pelvis to give you the maximum range of motion. And the actual, if you were to quantify it, it's not so much a lack of bending that they experience. It's more stiffness, and especially a combined rotation stiffness. So in some of the adult patients that I've had to do these, where I've had to fuse them to the pelvis for various reasons, the biggest thing is they have trouble, for example, turning around to wipe themselves or hygiene themselves. So in terms of picking stuff off the ground, your hips largely do that. So you shouldn't notice a huge difference there, but it's more actually, you know, in these maneuvers like getting out of your seat or turning around that you run into more problems.
There's another question around surgical robots, about your thoughts in terms of using it for spine surgery. Does it result in better clinical outcomes for patients, or does it make a surgeon's job slightly easier?
That is a great question. I think that's Tayaba who asked that, because it's a very controversial area. And I'll tell you it's controversial because the answer differs depending on who you ask. There are surgeons that use robots, there are surgeons that don't. I have used robots in the past, but I don't, because when I use a technology, I always think about what is it able to do that I can't do? And currently, surgical robots provide you with an arm for navigation. So basically, it allows me to navigate, which I can already do freehand. And the much better thing for me to be able to do this freehand is that I can feel what I'm doing. So I build some additional safety into it. Now, the robot completely takes that away from you. And here you see an example of a robot that I just showed you there. So this is a robot on the right-hand side. And basically, it allows you to do the same thing as what you can do freehand. So for me, it's better to be able to see what you're doing and then fly with instruments than it is to completely rely. There are situations in aircrafts that you can't rely on anything, but in situations of spine surgery, you know, I think better to have a well-trained surgeon who uses these technologies as assistive. And so therefore, in my practice, I find that robots do not offer any additional benefits over traditional navigation. In fact, have some drawbacks, which is why I don't use them.
That's good observation. I mean, yeah, because we hear a lot about robots taking.
It sounds very sexy, and it's often used for marketing reasons. And also robots are different for different specialties. For example, kidneys or prostate resections, robotic surgery there is different to the robot we have in spine surgery, because the robotic surgery there, for example, allows you to perform parts of the surgery, whereas spinal robots tend to actually just dock a navigation arm on. And so all it gives you is a trajectory which you can get anyhow. And this is very replaceable by, as I said, well-trained human surgeons.
We've got another question from Hans. Great. Thanks for the very nice talk. Could you please comment on your view on where the field of spinal surgery is heading? What is the next big thing in your opinion?
So that again is a great question. I think we are perhaps looking at patient-specific technologies and in particular patient-specific implants. Definitely is an area that is a very hot topic. Now, a lot of things in spine are incremental, just like a lot of things in everyday technology. So people make small changes, and when you look back over 50 years, you know, it's a huge difference. And that's what this Journey to Mars poster is showing, is that first you've got to put a telescope up in the sky, and then you can try and get an International Space Station, and then you can start doing more scouting. And so in terms of spinal technologies, I would say that people are looking at ways to try and make implants that are specific to the patient. People are making material modifications. People are making incremental improvements in being able to put these technologies into use that's more safe. For example, some of the more modern robots will have error margins. So that tells you when you're out, and you're never 100% in there. So it's basically saying, oh, you're deviating slightly, be careful. That is like the version 2 or version 3. And it's just like the iPhone. If you ask the iPhone designer, you know, how is an iPhone 12 different to an iPhone 11, different to an iPhone 10? I actually don't know. I still have one of those iPhones with the button because I like pressing the button. But I'm sure that they'll be able to tell you that every year they're making new and improvements. And if you look at an iPhone 11 compared with an iPhone 5, there are huge differences, but these are not massive revolutions, they're more evolutions.
Thanks, Yi. Well, we are on the hour at 5, and I just want to really express my thanks for taking the time to do this. And really, it's indeed, you know, even though I work in this area, designing implants, working with orthopedic surgeons, but it's always amazing to see, you know, how your personal view and you know, affect and in terms of your practice, how technology. So I think as engineers, it certainly it's good for us to interact closely.
I think, yeah, definitely. That is the most key thing. Oh, there's one more question. Do you want me to answer that?
Yeah, if you can.
Again, yep. The increase in spinal surgeries per capita basis has really taken off, particularly in the private setting in the last 10 to 15 years. In your opinion, are there improvements needed in diagnostics rather than surgical technology to select the right patients? That is actually a very good question. And so answering this, I would say that what we need is more data. We need to prove to a certain extent. And this is coming back to evidence-based medicine a little bit, in that what we are doing needs to be shown to be effective, and it needs to be shown to be durable over time. So, you know, like everything else in today's world, in the 1800s, it was steel and oil. That was the #1 commodity. In the 2000s, it's data. And that's why the biggest companies in the world are actually the ones that collect data, i.e. Google, i.e. Apple, or you make vaccines. So they're the two biggest sort of corporations in the world. And so what we are doing is trying to collect large-scale data. What we'll never be able to know, unfortunately, is what that patient would have been like had they not had an intervention, because you can't go back and say 10 years ago, if you didn't have this operation, what would you be like today? Alternatively, you can't go back and say 10 years ago, if you had an operation, what would you be like? So we have to collect large-scale data over long periods of time to be able to understand and to see that things are making a difference. Now, the good news is that we have that system in Australia. So we actually have a spine registry, which is actually set up through the University of Monash. But I won't plug the opposition. So what they do is that before every surgery, I actually get my patients to enter in the demographics, enter in how much it's affecting their lives. Then we collect what sort of surgeries they had, any complications, and we follow them for years and years. This is still very much in the pilot stage of maybe 2 or 3 years down the track. But I think this is the key thing, is that we need to collect these data over long periods of time, over large population, to actually understand this better, because we haven't done this before. And this is a relatively new concept, again, in the last 20 years.
All right, thank you. Thank you so much. Thank you everyone for staying so late and I want to express my thanks again to Yi for taking the time. And thanks very much. We will close the webinar at this point, and have a good evening.
Thanks, everybody. Thanks for having me.